Okay, I'm happy to introduce Ms. Di Natale Samuela. She's a fifth-year resident now since 1 year with us in our team, and she will present a very interesting topic which we have to deal as well, is portal hypertension. And I want to mention that we have also our guest with us, Professor Mühlhaupt from hepatology, who will listen to this talk. Thank you.
Thank you very much for your introduction. Good morning and welcome everyone. As mentioned before, today I'm going to talk about portal hypertension. I will start with the definition and follow with pathophysiology, etiology, clinical presentation, diagnostic workup, as well as treatment and preoperative preparation. Portal hypertension can be simply defined as an abnormal venous pressure elevation in the portal system. Direct measurement of the portal vein pressure, however, is invasive and requires the direct cannulation of the portal or umbilical vein. Alternatively, portal hypertension can be defined by the pressure gradient between the portal vein and the inferior vena cava, defined as hepatic venous pressure gradient, which represents the actual portal perfusion pressure and ranges normally between 1 and 4 millimeters mercury. Values greater than 5 millimeters mercury indicate portal hypertension, and values greater than 10 millimeters mercury correspond to a clinically significant portal hypertension, that is, when clinical complications such as gastroesophageal varices, splenomegaly, or ascites ensue. The knowledge of the pathophysiology of portal hypertension has changed dramatically in the past decades. When considering the pathophysiology, it is very important to look at the Ohm's law. The portal pressure is directly proportional to the amount of the blood flowing through the portal circulation and the resistance opposing this flow. Therefore, an increase in portal pressure can be considered a secondary to an increase in blood flow, an increase in resistance, or to a combination of both factors. In the past, it was considered that portal hypertension was a result of congestion to the portal circulation through the hard cirrhotic liver. In the 1980s, Kosman and Cohn showed that despite the increased vascular resistance, the splanchnic circulation was not congested but hyperemic. These contrasting views were the basis for two radically different approaches for portal hypertension. While the traditional congestive hypothesis led to the introduction and wide use of surgical portocaval shunt, the demonstration that an increased blood flow plays a critical role in provoking advanced portal hypertension led to modern therapies, including splanchnic vasoconstrictors as well as non-selective beta blockers. In 1985, it was shown that the increased vascular resistance was not only a mechanical consequence, but that there was also a dynamic component due to increased vascular hepatic tone. Now, new advances of the knowledge of molecular mechanisms regulating hepatic vascular tone, endothelial dysfunction, as well as its relationship with fibrin angiogenesis and hepatic vascular occlusion and thrombosis are now the basis for new current emergent therapies for portal hypertension. The impact of cirrhosis and portal hypertension on the organ system is still under investigation. On this slide, you can see the most recent theory. Cirrhosis and portal hypertension cause bacterial translocation through pathogen-associated molecular patent, which releases pro-inflammatory molecules and cytokines, and this causes splanchnic vasodilatation. This may have an effect on different organ systems such as the adrenal glands, the brain, the kidneys, and the lungs. Now, according to the pathophysiology, any condition that interferes with the blood flow or the resistance in the portal circulation may lead to a portal hypertension. Cirrhosis is the most common cause in Western countries, and all other causes account for less than 10% of the cases. According to their anatomical location, causes of portal hypertension are classified into post, pre, and intrahepatic. An isolated portal vein thrombosis may lead to a prehepatic portal hypertension due to an impaired blood flow, and Budd-Chiari syndrome and right-sided heart failure to posthepatic portal hypertension due to an obstructed venous outflow. Now, intrahepatic portal hypertension is driven by a high vascular resistance at the pre-, post, or sinusoidal capillaries. The main causes are cirrhosis, schistosomiasis, mostly in developing countries, as well as the veno-occlusive disease. The presentation of portal hypertension is mostly the occurrence of systemic complications. On this slide, you can see systemic complications of an advanced liver disease, and the complications of portal hypertension are mostly the same. First presentation of portal hypertension can also be an incidental findings of complications on imaging. Now, can anyone tell me what kinds of clinical signs are shown on these images? This is the next one. This is ascites, maybe this one.
Spider navy.
Thank you. And the last one.
Erythema palmare.
Very good. Thank you very much. Now, what are possible signs of portal hypertension in the laboratory examination? Changements due to portal hypertension correspond to changement due to an advanced liver disease and may include synthetic dysfunction, hepatic injury, and depending on the impact on other organ systems, renal dysfunction or cytopenia. I have another question. What kind of changements due to portal hypertension is shown on this image? No one. This is a recanalized umbilical vein, maybe the second one. The dilated portal vein, and the third one.
Esophageal varices.
Right, esophageal varices. So what is the diagnostic workup in portal hypertension? An accurate diagnosis can be made based on the presence of portal hypertension-related complication and the exclusion of other potential causes. One or more of the complications mentioned before, combined with clinical, biochemical, as well as imaging features of portal hypertension, are enough or sufficient to make a diagnosis. First, an ultrasound is recommended, which may detect signs and complications of portal hypertension. And second, a transient elastography, which values under 10 kilopascals in absence of clinical signs, ruling out a liver disease. Values between 10 and 15 kilopascal are suggestive for a liver disease, but further confirmatory tests are recommended, such as an upper GI endoscopy, liver biopsy, and hepatic venous pressure gradient measurements. Values greater than 15 kilopascal are highly suggestive for a liver disease. Now, these two examinations are non-invasive. As I already mentioned, the direct measurement of portal venous pressure, however, is invasive, inconvenient, and clinically impractical. That's why the hepatic venous pressure gradient is most commonly used and is defined as the difference between the free hepatic and the wedged hepatic venous pressure. On the direct access to the systemic venous system, a branch of the hepatic vein is reached on the fluoroscopic guidance, and the free hepatic venous pressure is obtained. Balloon occlusion of a small branch of the hepatic vein measures the static pressure in the liver sinusoids, and this is called the wedged hepatic venous pressure. And as already mentioned, the difference between these two pressures corresponds to the hepatic venous pressure gradient. Now, in cirrhotic liver, no decompression at the sinusoidal level is seen. That's why the wedged hepatic venous pressure corresponds to the portal vein pressure. Now, what are the different treatment options for portal hypertension? It is important to distinguish between curative treatment options, including or consisting of liver transplantation, and therapy option controlling the disease, such as pharmacological and endoscopic therapy options, as well as surgical portosystemic shunts, and the transjugular intrahepatic portosystemic shunt performed by interventional radiologists. Due to the limited time, I will only talk about the last two therapy options. Now, the treatment of a mild portal hypertension, defined as hepatic venous pressure gradient between 6 and 10 millimeters mercury, is the prevention of worsening after hypertension and decompensation of liver disease. The treatment includes treatment of the underlying disease, treatment of comorbidities such as obesity and no alcohol consumption. The treatment of a severe or an advanced portal hypertension is the treatment of complications. Gastroesophageal varices and gastrointestinal hemorrhage, therefore, is one of the most common and important complications of portal hypertension. Esophageal varices are seen in about 40% of patients with initial diagnosis of a child-pox A cirrhosis and in 60% in case of decompensated liver disease. Gastric varices are less common and have a lower bleeding risk compared to esophageal varices. Portal hypertensive gastropathy is characterized by an endoscopic image of these naked scale-like mucosal changements and can be a reason for chronic anemia. Now, the risk of subsequent hemorrhage is determined by the underlying hepatic dysfunction, size of varices, as well as the presence of high-risk stigmata at endoscopy, and ranges therefore between 5 and 75%. The 6-week mortality, however, reaches almost 20%. Now, without an adequate prophylactic therapy, and recurrent bleeding is seen in up to 80% within the first year, with an associated mortality of 30%. That's why prophylactic therapy and treatment of acute hemorrhage are crucial. Now, the treatment of gastroesophageal varices can be divided into screening, primary, and secondary prophylaxis. A screening is recommended at initial diagnosis or in case of a decompensated liver disease. If no varices or small varices are seen, a rescreening should be performed after 2 years. In case of large varices, an endoscopic variceal band ligation or non-selective beta blockers are recommended. If an index bleeding has occurred, secondary prophylaxis should be initiated to prevent a recurrent variceal bleeding. Combination therapy of endoscopic, variceal band ligation, and non-selective beta blockers are recommended, and in case of recurrent hemorrhage, an optimization of the medical and endoscopic therapy should be achieved, and a TIPS as well as surgical stent should be considered. Now, ascites is another common complication after of portal hypertension, and it is seen in almost 50% of cirrhotic patients within 10 years. The medical treatment consists of dietary salt restriction as well as diuretics. By signs of spontaneous bacterial peritonitis, such as hepatic encephalopathy, sudden onset of abdominal pain and fever, a diagnostic paracentesis is recommended with high serum ascites albumin gradient, as well as a high polynuclear cell count confirming the diagnosis. An antibiotic therapy should be initiated and albumin administered to reduce the risk of renal failure. In case of previous SBP, an antibiotic prophylaxis is indicated. Now, in case of refractory ascites or recurrent variceal bleeding, a transjugular intrahepatic portosystemic shunt, short TIPS, should be considered. TIPS is a procedure performed by an interventional radiologist via the internal jugular vein, and it entails the creation of an intrahepatic shunt between the portal and the hepatic vein. Portosystemic shunts are highly effective in reducing the portal pressure. Now, TIPS is a gold standard for therapy-resistant variceal hemorrhage and refractory ascites and can also be used for hepatothorax as well as in hepatorenal syndromes. Complications include technical complications such as puncture of the liver capsule in up to 30%, as well as stent occlusion, which is seen in 10 to 20% within 1 year. Last but not least, also stent infection, only seen 1% of the cases, but this should be aggressively treated with antibiotics. One of the most common adverse effects is the hepatic encephalopathy in up to 55% of the patients after TIPS. Now, what about surgical portosystemic shunts? Today, they are rarely undertaken due to a high complication risk, to a rising number of liver transplantation and the development of TIPS. Both surgical shunts and TIPS decompress the portal system, but due to a better calibration of surgical shunt, there is a potentially better preservation of the effective hepatic blood flow. And surgical shunts are still the last option in case of a TIPS stent thrombosis. Now, this is a study which was published in 2018, a systematic review which included 4 randomized controlled trials and compared surgical portosystemic shunts to TIPS for variceal hemorrhage in patients with cirrhosis. They found no difference regarding the 30-day all-cause mortality and post-interventional hepatic encephalopathy. Patients who received surgical shunts had a lower all-cause mortality after 5 years and less variceal rebleeding, reinterventions, and shunt occlusions. But this evidence is very low due to an overall high risk of bias because of inconsistency, imprecision, and a publication bias. Now, surgical treatment options for portal hypertension include surgical shunts, which can be classified into total, partial, and selective, as well as the Sugiro procedure and splenectomy. Total shunts lead to a complete diversion of the portal blood flow to the inferior vena cava, and indications are refractory bleeding from gastroesophageal varices, and the rest of hemorrhage is seen in almost 95%, but with a rate of 50% for hepatic encephalopathy. Other indications are also Budd-Chiari syndrome as well as a failed TIPS. Types of total shunts are an end-to-side and side-to-side, as well as the mesocaval shunt. Here you can see the side-to-side and end-to-side shunt between the portal vein and the inferior vena cava with conversion of the portal blood flow. Contraindications are extensive portal vein thrombosis as well as an occlusion of the hepatic artery, because in this case the liver would not receive any blood inflow. This is the mesocaval shunt. It is an interposition graft between the superior mesenteric vein and the IVC, and contraindication is a superior mesenteric vein thrombosis. Due to the shape, it is also called an H graft. With the size of the graft, you can calibrate the diversion of the blood flow, and a small graft leads to a preservation of liver perfusion, and a large graft to a complete diversion of the portal flow. Further, we have partial shunts. This is an 8 mm interposition portocaval shunt. Indications are also control of acute hemorrhage from esophageal varices with daily medical and endoscopic therapy, as well as a complicated Budd-Chiari syndrome. The aim here is to maintain the portal perfusion to the liver and to avoid the development of hepatic encephalopathy. Contraindication is, of course, a portal vein or IVC thrombosis. Now, one of the most known shunt is the selective, the distal splenorenal, also called Warren shunt. It is a selective decompression of the gastroesophageal segment, and the aim is also to maintain the portal perfusion to the liver. And hepatic encephalopathy is seen in under 10% of the patient. This kind of shunt is rarely used in acute hemorrhage due to the selective decompression, and therefore the bleeding control requires time. Compared to the other surgical shunts, it is also a time-consuming procedure. and contraindication is a splenic vein thrombosis. Here you can see the technique of the distal splenorenal shunt with the end-to-side anastomosis of the splenic and the renal vein. The last surgical procedure I would talk about is the gastroesophageal devascularization performed during the Segura procedures. Indications are also failing medical and endoscopic therapy, as well as an extensive portal vein thrombosis when TIPS and surgical shuntings are not an option anymore. The procedures include esophageal transection, which limits the blood flow from the portal to the central venous system, and an extensive periesophageal devascularization through an abdominal and a thoracic incision. The first procedure, let's say the original procedure, is the thoracoabdominal approach with splenectomy seen on the first image. The second is a complete portoesophageal disconnection, but with spleen preservation, seen on the second image. And the third procedure is an only abdominal approach with transection of the esophagus, seen on the first picture, splenectomy on the second picture, and ligation of the left gastric vein, completing the procedure on the third picture. There is also possible treatment for recurrent gastric variceal bleeding performed by the interventional radiologists. Here, exemplary, the retrograde balloon occlusion variceal ablation, which is performed in case of gastric varices and in patients with a naturally splenorenal shunt. The balloon catheter is inserted into the shunt and it is occluded. After that, sclerosant are injected to stop the bleeding from the gastric varicose. So last but not least, I would like to talk about the preoperative preparation, in this case for patients with cirrhosis. As already discussed in previous presentation, it is very important in cirrhotic patients to assess the severity of liver disease according to the Child-Pugh and MELD score. Patients with major abdominal surgery, here for example colorectal cancer surgery, have a high risk for mortality, and it was shown that patients with a higher Child-Pugh or MELD score have a significantly higher perioperative mortality risk. So in 2018, a preoperative checklist for patients with portal hypertension and cirrhosis was published. So I don't want to go too much into details, but I think the most important thing actually is to assess the impact of cirrhosis and portal hypertension on the other organ systems to reduce their mortality. So in summary, portal hypertension is an abnormal venous pressure elevation in the portal system. Cirrhosis is the most common cause in Western countries. Remember ascites and portosystemic collaterals as possible clinical signs of portal hypertension. The treatment should be divided into curative and treatment options controlling the disease, and a preoperative checklist to reduce perioperative risk. Thank you very much for your attention.
Yeah, Samuela, thank you very much for this very, very good presentation. Thanks also to Dr. Oberkofler and Limani, I think, who did the supervision. I mean, the first thing is this is complex. I mean, you show many different clinical pathophysiology, treatment, and I think this is a topic, and you highlight very well, for everyone. Portal hypertension, cirrhosis, increase the risk of surgery. So every general surgeon should know that mortality is high, and these patients do better when they are in a center where there is expertise in hepatology and liver surgery for this patient. A cholecystectomy done in a cirrhotic patient is a very high risk operation, and many general surgeons with no experience can be the nightmare of their life to go and to do a laparoscopic cholecystectomy in a cirrhotic patients. I want just to make 3 points here. One, also for the liver surgeon, for us, those who come, who assist us in surgery, when we do a big liver resection, I always ask the question at the end, how can we predict the outcome? And the answer here is you put your finger on the portal vein. If it's hard, the outcome will be poor. If it's very soft, the outcome will be good. This is not as simple as that, but it correlates very well. Studies have been done showing that the pressure is more than 20 or 17 or 21, then the outcome is very poor. So that's simple things that also we can test with this. You present a lot of surgery. You can imagine how complicated are this surgery. The problem today is to find someone who can do this surgery, right? I mean, before, when there was no tips at the time, even general surgeon could do a portal cava shunt. Today, even liver surgeon or HPB surgeon have not much experience in doing this, so they are not doing this and offers maybe a procedure that is not as adequate of surgery. You've shown, I mean, this meta-analysis, you are like that very well. It's very difficult to interpret. There have been attempts at randomized trial, very difficult to compare tips with, say, a Warren shunt or something like that. But one point is that very few surgeons today are able to do either a Sugura or even a Warren shunt, which still has an indication. Just to point to the wrong operation because of that, several surgeons do a splenectomy, because that everybody knows how to do it, and the splenectomy is contraindicated in most cases of portal hypertension. It makes the situation worse, except maybe if there is selective with gastric varices. Otherwise, it should not be done, and we regularly see patients operated sometime a long time ago by a splenectomy, where there was no indication here. I just maybe have some question now for Professor Mühlhaupt or Professor Dudkowski here about the tips, because I think this is a treatment that is done a lot of time, and I would like them maybe to tell us, maybe Beat, what's the role with tips in bleeding? You have all this treatment, relatively old, what you showed at. I don't think that, I mean, I'm not aware about many things done recently. The big interest was in the 10 years ago. So what will be today, Beat, the indication for tips or emergency tips in the setting of bleeding or ascites? In this situation, and Philip, for Professor Dudkowski here in transplants, some time ago, everybody had the tips, but because we thought if you decrease portal pressure, the transplant will be easier. And today I think we do that very rarely, and maybe we'd like to ask Professor Dudkowski to tell us in which situation tips will be a good thing prior to transplant. So maybe Beat first.
Okay, I mean, I think if you talk about tips and portal hypertension, I think you need to distinguish between bleeding and ascites. In bleeding, obviously, as you have told, it's a good indication for secondary prevention if secondary prevention fails. But I think tips moved ahead a little bit into the so-called early tips or the preventive tips in patients with high risk of rebleeding. And these are patients with child PUC cirrhosis or child PUB 8 to 9 with active bleeding under endoscopy. These patients actually should get an early tips. This means within 24 to 72 hours after the initial bleeding, because it has been shown that this reduces mortality. So I think the tips moved a little bit ahead. It's used earlier than it was in the past. And I think this has had a big impact on outcome of variceal bleeding. And then I think for ascites, I think it's if you have a lot of paracentesis, it's an excellent option. I like it especially for hydrothorax, because hydrothorax is a difficult situation. And those who have talked to me know that I don't like if the patient has a tube in the chest, because a cirrhotic patient with a chest tube for fluid usually doesn't recover anymore, and he will remain with this chest tube until transplantation or complications ensue. Therefore, for hydrothorax in a cirrhotic patient, I think TIPS is almost the first choice treatment.
So my comment in terms of liver transplant, I prefer to have a TIPS instead of a portal vein thrombosis. So our percentage of TIPS patients is relatively high compared to UK. It's regularly helping us for the transplant surgery, because there's less ascites and less portal vein hypertension and less bleeding therefore. But of course the nightmare is a dislocated TIPS. if the tips is dislocated to the, for example, to the right atrium, to the heart, then it's very difficult to clamp the upper cava, and then we usually have to extend the incision by an sternotomy, and so that's difficult. And the worst scenario is if the tips is dislocated downstream in the conference of the splenic and the portal vein, then of course it's very difficult to, or even impossible to take the tips out, and then we have to find another inflow for the portal vein, and that's usually a disaster. We had that only in 2 cases in, I think, 20 years. So generally, I think TIPS is very helpful for the transplant procedure, but it need to be controlled, and the transplant surgeon must be aware about the location of the TIPS before he goes in the procedure. That's my comment.
Okay.
Thank you.